going across the pond to Europe. Stefan Rammelt is our moderator from Germany. Good morning, guys, or maybe it's already afternoon for you guys, but good morning. And Stefan, over.
Yeah, good morning from Central Europe. It is 7 o'clock here, and everybody has had his first coffee, I guess. And we're going to start with a very challenging topic. I'm glad I have two very experienced surgeons who help me out with that. So, navigating complications in ankle fusions. This is the little town I come from, Dresden in Germany. These are my disclosures, but they're not too directly get to the talk. These are the panelists. So Tim Schepers from Amsterdam, Netherlands. He works there at the University of Amsterdam Medical Center. Is a trauma and orthopedic surgeon. And Lubomir Kopp, our neighbor from just across the border in the Czech Republic, Usti nad Labem, who works there in the trauma and orthopedic center with a very high load of difficult cases, polytrauma patients. They both help me every year with the practical courses in Dresden, and they also help me writing that manual, contributing chapters to it. So I'm glad they are here with me in the early morning.
Thank you, Stefan.
What are the reasons for failure in ankle fusions? So this is an ad for Total Ankles, and they basically assume that all people with an ankle fusion are screwed. But in fact, an ankle fusion can be very helpful and can provide very much pain relief and functional advancement for patients if they are done well. Unfortunately, there's a lot of technical errors that lead to malunion. And those famous series that are always quoted in the literature with adjacent joint arthritis in 70 or 100% of cases, many of those patients are fused in a slight equinus or varus, because the cases are from the 1980s, 1990s, and when people still thought that, for instance, ladies have to be fused in a slight equinus to wear fancy shoes. Now we know that these people who have fusion in equinus are really screwed. Also, non-union might be faulty technique, not correct debridement, inadequate stabilization, but also external fixation as a fixation device is associated with more non-unions. And then, of course, we have to look at the patient risk factors. Usually, we don't fuse healthy patients who have fine ankles. We fuse patients with some disease, post-traumatic arthritis or idiopathic arthritis that have sclerotic bone, necrotic bone, and so we have to look at these factors too. So what to do? There's not too much out there in the literature, so I do not need to talk too much about this. But of course, the group from Seattle, from Harborview, among Ted Hansen, who passed away last year, did a large series, a relatively large series. At that time, it was the biggest one of 20 revision fusions. And like in the other series, it's split more or less evenly between non-unions and malunions. And some of the non-unions are infected, some are associated with avascular necrosis. The group of Ted Hansen advocated compression screw arthrodesis, so internal fixation for the ankle with the ankle in neutral or a slight valgus in the frontal plane. They used a lot of bone grafting for their revisions. They had to add 4 subtalar fusions. Some of the patients already had fusions in the subtalar joint, and they had to add 19 additional procedures, soft tissue procedures, fusion procedures, and even 3 amputations for patients who got chronic infections. So it is not free of complications. The fusion rate also is not as high as in a primary ankle fusion. At first attempt, 3/4 of the patient achieved fusion. At the final revision, 85%. So some patients, 15%, still went around without solid fusion. Time to fusion was 6 months finally, so longer than in a primary ankle fusion. In the end, 85 patients were satisfied. Not to say they were happy, but they were satisfied. They were better than before, and they would undergo the same procedure again. And the reason for that was that almost all of the feet were plantigrade, and there was still some sagittal motion in the Schepers joint. This is the proposed technique by the Hansen group for ankle fusion. So the fibula is used as an onlay graft if it is still there. This group advocated slight posterior translation of the talus for getting a stronger lever. This is one way to do it. Everybody agrees flexion must be neutral and there must be a slight valgus of the heel. This was a small series from our group. It was published in German, but has a lot of images in it. One non-union, most of it were malunions. Interestingly, 2 in equinus, 2 in a calcaneus foot in patients with neuromuscular disease. They were not followed that long. Almost all underwent corrective osteotomies and revision fusion. Finally, those 5 patients fused and were satisfied. And this is the SWIP technique. And since he was my mentor, I took this from him, measuring the faulty position and then calculating the correction. And this is what we call Purman's navigation, just with the K-wires in the angle that has to be corrected. Of course, nowadays you can do this all with some fancy stuff. And of course, the calcaneus correction has to go the other way. And so this is equinus can be corrected in closed wedge fashion, calcaneus correction in an open wedge fashion, or here, as we see in a modification of a Blair technique, where part of the tibia is osteotomized further up and then shifted down into the talus. This is also very helpful if there is avascular necrosis. In the end, patients have to be plantigrade. And one last series I want to draw your attention to is that of the group of Draw Paley from Baltimore. They worked a lot with the Ilizarov technique with callus distraction because of their patients. Most also needed limb lengthening. So the osteotomy was done and then the correction was achieved with the frame, and then they started limb lengthening after that. They had to wait some time, but then had a fusion rate of 100%. Patients were all plantigrade still. Not every patient was happy. A lot of minor complications, but also a lot of complications that required revision because during the time in the frame, there might be also some axial deviation, or if the callus closes in too early, repeat corticotomy. So this is a technique that is very demanding and it requires a lot of experience. So we're gonna jump into some cases and we start with a simple one with a non-union, which is unfortunately still happening after ankle fusions. And of course, Murphy's Law, this happens in medical doctors. This is a not too old medical doctor, 44 years old, has persistent pain 2 years after ankle fusion, no obvious malalignment. So this goes more or less straightforward to a repeat fusion. You can see here in the CT scan that there is absolutely no direct bridging of the bone over the whole area of the ankle joint. And of course, at that stage, before embarking on surgery, you should have a look at patient's factors like smoking, osteoporosis, or just vitamin D deficiency, diabetes, and of course, the compliance of the patient. So my questions to the panel: do you operate these more or less complex cases in smokers, or do you demand that they quit smoking?
So always the attempt should be done to force them to quit the smoking. I'm not quite so successful in our population in Czechia, so perhaps some of these end up being operated even when they are still on some 2 or 3 cigarettes a day. But I always try to force them to quit smoking.
So in our population, I think in trauma patients, the number of smokers is around 30 to 40%. Luckily, in the rest of the Netherlands, it's getting less and less because they made it so expensive. You can buy a car for 1 year smoking about now. I tell them to stop smoking, and I tell them if we do a revision and it fails and they didn't stop smoking, it's their fault and definitely not mine. So that's of course not entirely true, but it helps them see the need to stop smoking, because the rate of non-union infusions is 3 to 4 times higher in smokers than in non-smokers.
Absolutely. So I fully agree. You have to do anything to try to stop them smoking. There are nicotine patches and anything you may try. Sometimes the patients are really happy because they say they just feel better. They don't have to cough so much. And also the wives are happy with that. But some restart after having the surgery, but it definitely helps. And you have to tell them this is already a failure. And we both don't want another failure, which can be catastrophic.
Yeah, and
So here in this case, it was a medical doctor in internal medicine, so he was not smoking. We went on to revision fusion, and in these cases, we use bone grafting from the patient, so autograft, because that has all the growth factors and the blood pieces that we would otherwise have to buy for a lot of money, for even more than a car. And of course, you have to check the alignment. And then this is a combination of screw and plate technique for the revision fusion. It already looked quite solid after 12 weeks. That one screw peeked out a little bit. I would have taken it out, but he went to his community orthopedic surgeon and he put it in again. So this is the patient 1 year after revision fusion, solid fusion, good alignment. So this patient is happy. Any additions to that, if it doesn't fuse, or if the patient has poor bone stock and you think you might do something else, any medication or any growth factors that you would add at that stage, at the first revision?
Probably not.
Having such a young patient, I won't think of a primary insertion or injection of some growth factors, perhaps in some older patients or some more compromised patients, not in a 44-year-old young active man.
No, I agree. And Stefan, when do you decide to add, for example, the fibula as a graft rather than taking the pelvic graft? Because the pelvic graft also has quite a bit of burden to the patient. So when you have an anterior incision, you can add a lateral incision to go transfibular and add the fibula as a graft. Would that be an option for you, or when do you decide to go through the fibula?
I rather try to use the fibula, as in this case, as a kind of strut graft. So the fibula is still there. If I have to osteotomize it, then I would add another screw that hooks it onto the tibia. So the fibula definitely has a role in fusing the whole thing, and we always include it into the fusion. Some people don't. And so most of the time I go for the iliac crest. In my experience, the morbidity, the donor side morbidity is quite low, and we have good experience with that. And this really is a bone where you have, I think, more cells. You can use this even for transplantation of cells, for stem cells transplantation. So I think this has a high potential. You can get more. The fibula has a thick cortical shell, so there's not so much spongy bone into it. But I like to use that cortical strut as an additional graft, like in this case. So just having the fibula there to help with the fusion. So now it gets a bit more complex. We have malunion and non-union. So maybe these things contribute to each other. Here we see a 62-year-old male with that non-union and additional equinus. Here you can see the loosening of the screws. In these cases, after taking out the screws and that loosening seams and all the bad bone, we needed a structural graft. Again, we took it from the pelvis and we changed from a screw to a plate fixation in that patient, and it seemed to work out. And this is a problem that we will frequently encounter. So in most of the times, in my experience, if we have a malunited ankle fusion, then the adjacent joints will have to be addressed, and they are not innocent. So here we have a sad case of a relatively young lady, had an anterior pilon fractures. Of course, they are nasty because they really destroy the cartilage more than they complete the type C pilon fractures. This patient went on to an early fusion. You see where the graft was taken from the tibia, but that's not the problem. The problem is the equinus, which is 11 degrees in her case. You see there is some 10 years after the fracture, 9 years after the fusion, there is severe arthritis in the talonavicular joint. There's some arthritis in the subtalar joint. And these are the CT scans. So the talonavicular joint looked fused in the X-ray, but it isn't fused. It is severely arthritic and it's painful on every step. So, of course, in these cases, you have to correct it. And this patient already, starting from the injury through the primary fusion, was a bit shorter on that side. So we decided, although it was a bit more strenuous, to do an opening wedge supramalleolar osteotomy, bringing in the wedge with the big part behind to keep the length of the limb when the patient is taken out of equinus. And of course, we had to add the talonavicular fusion. 8 months later, alignment was improved. Talonavicular joint was fused, ankle was still not fused, and she had some pain over the fibula, which we just osteotomized, but we didn't fix it. So what to do now?
I would look at a CT scan if you have that, and then probably add additional implants to stabilize the. So it's probably a non-union because of some residual instability. So I think I would add some additional screws, perhaps an axial screw in the fibula to help it fuse.
Yeah, that's exactly what we did. So we added a second plate. So we just exchanged one plate for 2 plates. The fibula at that time was fused to the distal part. So we just resected a little bit from the proximal part. This is now already 1 year later. Patient is now happy because for the first time she can walk without pain during her activities of daily lives, of course, not to mention any sports. And she still has some motion in the navicular cuneiform joint and the calcaneocubital joint, and maybe it also helps in her case that the subtalar joint is still there. So she has some residual motion to her midfoot, and so she can walk. I haven't seen her a long time, which might be a good sign. But of course, this foot is already relatively stiff, so it's even the more important that the foot is in a good position.
Does any of you have some experience with resection arthroplasty of the TN joint, where you resect only a small portion and put in a fascia lata graft to maintain any motion, a little bit of motion in the TN joint?
I will have one case where we did a similar thing, but typically this is one I would sometimes do in Charcot patients where I fuse the hindfoot and I still feel for correction of the forefoot. I have to make it a bit more sloppy. In those post-traumatic cases, I want to have also a solid midfoot. I rather go for a fusion of the talonavicular joint. But I will present a case where I did something similar.
Yeah,
so here, this is the worst malunion we have seen. The patient is in equinus. Fibula is already resected in that case. Adjacent joint arthritis in the subtalar joint more than in the talonavicular joint. So I try to save the talonavicular joint whenever possible, because this is the hip joint of the foot where the foot evolves around. And so this patient again has 10 degrees of equinus. And so we did a closing wedge osteotomy, and we added a fusion of the subtalar joint and did a arthrolysis to the talonavicular joint. And this is what you hope to achieve. You hope to at least have some time for the talonavicular joint. And this is the worst case here. This is what we would call a iatrogenic clubfoot. The patient is fused with anterior shift, with equinus, and with a severe varus, so he's barely able to walk. He also has a malformation, a vascular malformation, but that's not his problem. 10 degrees of equinus, 24 degrees of varus, and anterior shift. So he was barely able to walk, not even with his 8-kilo shoe that he brought on. So here we have to do a triplanar correction. You see again, poor man's navigation with the K-wires. We have to control for the equinus, shift the talus back, and we added the subtalar fusion also as a closing wedge fusion to get rid of the hindfoot varus. And this is the patient 1 year later. He's plenty grateful to walk again and has smaller shoes. So this hindfoot correction also corrects the whole alignment of the forefoot. Now it gets even worse with infection and AVN, and of course this happens after severe talar fractures. So this is one of the rare cases of aviators as stragglers that we see in Germany. This patient fell with a light plane and had a free fall of about 40 meters. He survived as a polytrauma patient, and amongst others, he had an open complex foot injury. We called it a floating talus because both the calcaneus and the tibia were fractured too. So these pieces of the talus were floating around, and we tried to save that with early fusion. And the free flap that was also brought on very early to give this patient a chance to heal, but it didn't heal. He got a septic necrosis of the whole remaining talar body, so everything had to be kicked out, including also the talar head. And then, of course, after infection, first you have to bring in some antibiotic spacer. In this case, it was a ton of antibiotic beads that were brought in. And then after the infection resolved, another month of debridements and negative specimens, we did a tibiocalcaneal fusion with the Elizarov frame, so a compression fusion across the external fixator. And of course, now the talar head is gone. And so we did some kind of resection arthroplasty here to the whole Schepers joint. And now the tibia and the calcaneus, they still connect a little bit to the calcaneocubital joint. And this is, Tim, some kind, I would say, of a resection arthroplasty to the talonavicular joint, because the talar head is not there anymore. And this patient was almost pain-free when walking. The problem was he was about 6 centimeters shorter, but he underwent around 40 surgeries for all the injuries he had. So he was happy to have a heel lift, to walk around with a plantigrade foot. The flap was saved with a single flap advancement. And so he has a huge heel lift, but he doesn't want any more surgery. This is 2 years later. I saw him just recently at a bus stop, and he's now more than 20 years out from that surgery. Here we have a patient, a failed ankle and subtalar fusion, unable to walk, already 2 attempts on ankle fusion. Again, we revised it. We went to a more stable implant with a retrograde nail, bone grafting, but it didn't work. He got infected. You see the graft was spat out to the front. The nail was infected, so we had to remove it, remove every hardware, and we put an antibiotic cement spacer in. And then the infection resolved. So what to do now? Any suggestions?
So thinking of the muscular technique that you are now performing, you have to get some graft somewhere. For these quite a big defects, I opt for the reaming of long diaphysis, so femur or tibia, getting a good quality graft, and then some rigid fixation in my hands, in this case, perhaps for a posterior approach with a posterior plating that can act as a tangent bend plate for the anterior part of the pilon and the rest of the tails. So it would be bone grafting and plating from dorsal.
Yeah, I think you might want to use a structural graft like pelvis or head of femur. I have seen cases where they used the fibula as an intramedullary graft to fill the old defect from the tibia nail and then add a lateral plate. So if you have a lateral incision, to use your fibula as a nail, and then you can add like a Philos plate on the lateral side to stabilize it.
That's interesting. That was the very first hindfoot fusion with a nail, was a fibular graft that was cooked and brought in. It was done by Erich Lexer from Königsberg in former times Germany. Now this is part of Russia. And he did it in the 1880s. So this was the first hindfoot fusion I came across. This paper is published in German, very interesting. So he cooked the fibula and reamed it and ran it across the calcaneus, talus, and tibia. And I agree, you would need quite a lot of graft. So just taking out everything you can get from the pelvis would probably not be enough. Now, this was a patient who could not and did not want to quit smoking. And this was him 3 years later. So I saw him clearly. And you can see the masculate technique. So it's just part 1 of the masculate technique. It seems to work. So there's a lot of callus formation around that cement. No infection. Solid foot, a stable foot. He walks on it. He has, of course, orthopedic shoes. He does not want any more surgery. And I did not want to operate on him anyhow, because he was not the most compliant of patients. So this is the last follow-up I have. It's 4 years. He had, at that time, a loosening total knee, so that he had other problems, but the ankle was stable. So this might be a bailout in a patient you don't want to touch anymore. If there's some good reaction from the bone around that, and this is the core of the masculate technique, you can as well leave the spacer in.
Yeah, just be
There was a
aware that
specific
even
situation
after...
where you...
Sorry,
Tim, speak.
So after several years, you can still get an infection of the cement spacer. So you have to be aware of that. So sometimes even after 5 years or more, patients get a red swollen ankle or a foot where there's a PMMA cement spacer, and then you still have to take it out and maybe change it for a new one.
Absolutely.
I wanted
Sometimes
to
there are
mention...
case reports of 20 years cement spacer. I just had to take one out from the subtalar joint because it dislocated over the years and then pushed against the fibula. So I might be prepared to see him again. Lubos?
And in this specific patient, you still had some contact in the posterior part of the fusion of the bone. So perhaps this was not a specific case for promoting the first stage of musculate as a final treatment. I don't like to have the cement spacers there for longer than 1 or 2 years because, as Tim said, you can get it infected in some situation or occasion that would not be beneficial for the patient. So I try to force them to undergo the next stage surgery.
Okay, so maybe I'll see him again. He must be now 8 years out or so. But I'm prepared to see those patients back. And if I have a 10-year or 15-year follow-up, I will probably report it. So now this is a very special thing. And this also then smoothly goes into Tim's case. The Charcot patients, of course, they have very special conditions. This is a patient not too old, but a severe diabetic neuropathy, not able to walk, chronic ulceration. And of course, if this gets severely infected, then we speak about a below knee amputation. But we tried to save this with realignment. You see the heel doing surgery. We put it out almost to 90 degrees of mal position. We still managed to hook the nail on to the calcaneus, because the calcaneus can be pretty worn out in those cases. This was the patient when we saw him for first follow-up. And this is the result at 3 years. So this might be considered a failure because it is a non-union. But I would think in a patient with a Charcot foot, where the aim is stable, well-aligned foot that is chewable, so he can walk in a special boot. For the first time since many years, he is able to walk again anyhow. And so I guess in these patients, a solid fibrous non-union may also be considered a success. Not sure if you agree with that, but I did abstain from any more revisions in this case.
Definitely.
Absolutely. Anything else than an amputation is a win.
Yeah. All right. So this is my summary. And avoiding failures is probably the most important thing, because there's few things that are worse for the patients than a failed ankle fusion. An ankle fusion that is either just a non-union, but even worse, a malunion, because this wears down all the other joints in the foot and sometimes leaves the patients unable to walk. Malunion has to be fixed with realignment. So again, to quote Ted Hansen, he said the three most important things in foot and ankle surgery are alignment, alignment, and alignment. Non-union has to be fixed by erosion fusion. You might consider adding bone grafting, orthobiologics, ultrasounds after that. So anything that makes the patient heal, and of course work with him on his comorbidities, diabetic medication, and on smoking. If there's infection, necrosis, anything that does not belong there has to get out. Necrotic bone will never heal. Get out anything, do some antibiotic spacer, and of course exchange it with a graft in 90% of the cases with the musculate technique. And of course you can also add this, add a frame, and do this for limb lengthening. Treat the adjacent joint arthritis. If not yet too bad, arthrolysis is of course preferred, but sometimes you have to do a fusion, and sometimes you even have to do a corrective fusion of the adjacent joints and treat the comorbidities. So that was it from my part. And now I think we can go to some more cases and discussion. Is there anything in the chat?
No, there came no questions, Stefan. So I think that we can move forward to Tim's case and discuss this case. Perhaps something would appear there.
All right. So, Tim, you take over this time to switch slides.
Excellent. So this is a 60-year-old male patient. He's only 130 kilograms because he used to be 140, but he got a gastric bypass. He has more than 10 years of diabetes, and he was treated 1 year prior with a triple fusion because of a Charcot foot with a rocker bottom, and that part healed well. Then he went into ankle arthritis with a little bit of talar avascular necrosis. And this is the procedure that was done elsewhere. And similar as in one of the cases by Stefan, the medial screw backed out after 6 weeks of non-weight-bearing cast. He got 6 weeks of weight-bearing cast, and the medial screw backed out. So they went back in and they tightened it. And this is how he came to us with these images. So any suggestions, Lubos or Stefan?
So we see quite severe loosening. We see a big bone defect already present there in the pilon region. So having this patient as a Charcot patient, opting for some perhaps more rigid structure or more rigid fixation than screws. So either plate or nail, if it's feasible in the revision. Would
you do any additional imaging?
Yeah, thinking of the infection, that's always the issue. The low pathogenic bacteria leading to some malunions or prolonged healing. So either get some culture swabs or even some samples from the area, or remove one screw, put it on sonication, get some material from that, and observe if there is no chronic low pathogenic infection that can hinder your success.
Yes, Stefan?
Yeah, and that is always crucial. Rule out infection before you start refusing. And also, I think a CT image would be good to see which of those joints has fused, because the plate goes all the way to the midfoot, and how large the defects are. And I think you did that.
Next slide, yes. So this is the PET CT scan, and then you get both the CT images and some information. It's definitely not 100% sure, but you get some information on whether or not there is a infection. And we found out that if you calculate the SUV max value at the hotspot, if it's more than 4, then it's too high to be just bone growth or healing fractures. So if it's more than 4, then it's highly likely an infection. And I believe in this case it was around 10. So we had a strong suggestion that there was an infection as well. So what to do next? Do you still want to go? Yep.
This definitely has to be a staged procedure then, taking out all the hardware, taking out all the bone that doesn't look good, and get at least 5 bone samples for bacteriology to see what the germs are. And then you can, even if you opt for putting in a cement space, then you can even mix a specific antibiotic to it to really act against the germs that are there.
Yeah, agree.
It's beneficiary to know which bacteria are living there before you implant the spacer, because then, as Stefan said, you can adjust the antibiotics in the spacer for the specific type of bacteria. And then thinking of the final surgery, then always having such a big bony defect there, because in this case you would have to resect at least 5 or 6 centimeters of the distal pilon and of the area of the hindfoot. Then discuss with the patient the possibilities of the foot or leg shortening, or of some type of implant that would be structural and would hold all the construct in this perhaps a bit longer hindfoot.
Yeah, so we did a stage procedure. Next slide, please, Stefan. So we opted for the Liesroff frame, did a little bit of shortening, removed everything that we were able to remove, and we added, I believe it's called Cerament, an absorbable antibiotic cement with gentamicin, and we added vancomycin as well. Not entirely sure if I would do the same now. Probably I would have used PMMA cement, just like Stefan did, which gives also a little bit more structural stability. because this absorbable cement, it was gone after a couple of weeks only. So I'm not entirely sure if I would do the same now. So we treated him for 12 weeks with antibiotics. Unfortunately, he really disliked the frame, and that's a common issue with patients, even the ones who have a bit of polyneuropathy. They can still sometimes really can be really bothered by a frame like this. Next slide, please. So this was 6 months later, I think, with a cast, because he wanted to get rid of the frame. There was a little bit of a sticky union, but definitely not a full union. And he didn't want to do anything for a long time. And all his cultures came back with Staph capitis, which was treated well with the antibiotics that we gave. Next slide. And this is 2 years later, because he didn't want anything to do at that time. And we used the fibula as a graft. And in this case, we used the femoral list plate from the lateral side to fuse the tibia to the calcaneus. There was almost no talus left anymore. And again, we used the fibula as a partially intramedullary graft. You can see it a little bit in the tibia there. Then we waited and see. Next slide, please. So this is 2 years later. And even though the fusion was solid, one of the screws came out. And this time we decided not to put it back in, but just remove it. We sent it for culture and it came back negative, and he had no more complaints after that. And we even have almost a year later follow-up, still doing well, still happy with his result. And I just discharged him from follow-up with a solid union. Anything you would like to add, or would you have done differently?
That's the issue of the defect that you have to fill with some structural graft. And as in this case, Tim, you've used the fibula as a structural graft, which can maintain the hindfoot length and the height of the hindfoot. So this is, I think, crucial, because having just a soft cancellous bone graft would not lead to good healing, even with this quite massive implant, this quite biomechanically strong implant. So I think that your way of treatment was absolutely correct in this case.
Thank you.
Yeah. So I also have mixed experience with this type of cement. Lubomir, I think your group has tried some bioglass that was quite successful in infected cases, even without antibiotics.
Yeah, we're working for at least 12 or 13 years with the bioactive glass, the original one from Finland. And so we can now have quite mid and long-term results, which are brilliant. I did not believe that something can work in such a good way. So we are in filling up the defects. We are mixing the bioactive glass nowadays with the cancellous bone graft. We're even using the structural grafts mixed with the bioactive glass and the cancellous grafts. And we use this in the second stage of the muscular technique, which I would show in my cases, with a great success, because we do not have to have such a long period of antibiotics administration. We can shorten up this phase on just several weeks, and having a very low rate of reinfections in the terrain that we had used the bioactive glass. So that's also perhaps the answer on Selene's question.
Yeah.
Selene did ask, do you like using any biologics? So the one point is the biology of the own body. So these are the autologous grafts, either structural or cancellous, and then anything that we can add that can help, growth factors or this type of bioactive glass.
All right, so I guess you have some cases too, and we are looking forward to see them.
I will share the screen and we'll get to the presentation. Do you see it correctly?
Yes.
Yeah, perfect.
Yes.
So I've chosen two cases. The first one should illustrate the issues that Stefan had already talked about. That's the biology and biomechanics of the often failed ankle fusion following the post-traumatic arthritis. So you always are facing several issues. That's in the first stage, the poor vitality of the whole area. You have the dead cartilage there, the bone that is not healthy enough. You have sometimes compromised perfusion due to the surgeries or due to the primary injury. And you, in many cases, have there multiple approaches, as the colleagues had tried to solve the primary fracture and then perhaps the complications. You have the soft tissue scarring, which endangers you performing your approaches in means of hitting some structures that can harm the patient. And in many of these patients, what I see in my patient group, you have chronic pain, sometimes even developing into the oligoneural dystrophy, the chronic regional pain syndrome, which can be a very debilitating issue, as I would present you. So this is the case, very similar to the one that Stefan had shown, a very young man, 39 years old, male, healthy, active, with a high energy trauma, a B-type pilon fracture. You see these die punch fragments, small ones. This was some 13 years ago. So at that time, we've opted for the phase treatment. That was just the casting the patient, scanning it, and then planning it, which is not optimal. Nowadays, we would opt for the stage protocol with the X-fix and the scanning afterwards. Then it was treated using the central ventral approach and putting all the small fragments back to the joint surface and fixing it with a pre-controlled 3.5 millimeter plate, which in our hands nowadays is not used anymore because it's too bulky and you can harm the vascularization and the vitality of the small fragments when putting so big screws in these. But at those times, that was the only available metal that we had. So this is the situation 7 days after the primary injury, as we've opted for the second stage of the conversion, and the situation 6 months later, and we see there is a big defect, metaphyseal defect in the bone, and what's even worse, there's a huge defect in the cartilage in the joint. That's the entire anterior part of the pilon that had disappeared due to the avascular necrosis and due to the energy of the injury that had caused the situation. The patient has now pain when walking and had lost his range of motion. So my question to the panelists, what would be the further steps in this patient in your hands? Would it be just some bone grafting or perhaps some cartilage transfer to this area? Or would it be fusion, or even when we are in the session of total ankles, would it be a total ankle in this case? What do you think?
So I think that you might want to opt for an arthroscopy to see if there's any cartilage left, but a little bit more that it came upwards, where you can graft and bring it back down. But I'm skeptic that is going to work or that it's going to show anything vital. In my personal opinion, but that's because I don't do them, and total ankle in this age group doesn't work well, and high chances of revision. So then probably you're left with a fusion. I know there are people that transplant entire joints, but not sure if that's already something that is available for every patient. So I think from all the options that you mentioned, fusion is probably the only one with a known acceptable success rate.
So we thought the same way, and we've performed a classic Hansen type ankle fusion modified by ZWIP and promoted by ZWIP in Europe. That's the 5-screw fusion. You see it on these two pictures. So that's 1 month after the diagnosis or after performing the CT. And you see that it was a classical type. So we fused the fibula as a strut graft, supporting the fusion from the lateral side. We see the positioning of the home run screw, and we see a good alignment in this area. That the things that were perhaps not correctly addressed were the structural defects in the metaphysis, where we've put just the cancellous bone graft. Then we see the situation some 6 months later, and it came to development of a non-union. We see the loosening of the screws, and this is the CT that had been performed. No bony bridging in this area, even though the contact is there. The patient is painful, has quite a low healing potential in this area, and has obvious instability in the fusion. So what would be the further steps for you?
Well, if there's pain after fusion, and non-union is always the first thing to think about if there's no malalignment. So this has to be a refusion, I think.
Yeah, there was
with bone grafting, with some more bone grafting.
Yes, yes. So that's what we also opted for. Some 2 months later, after making the diagnosis, we went there again, used again the central anterior approach, and performed the plating as a method that is perhaps of bigger stability and mechanical importance for the construct. We can even add the compression on the side when at first fixing the screws into the talus, and then using the cancellous or cortical screws, putting in the compression holes of the plate there, that you can add compression on the side where you have the non-union. Of course, the bone grafting that has to be done properly, even with the corticocancellous bone grafts grafted from the iliac crest, or with the graft from the long diaphyseal bones. And we see that after performing this construction, we have some healing potential there. 6 months later, it comes to bridging, the bony bridging, and we have the situation 28 months after the primary injury, after the metal removal, because these implants are quite bulky, so they bother the patient, especially in this area in the front where they have the problem then by walking with the shoes. So we've removed the plates, and we see a nice fusion in, I think, correct position that is not much equinus. So is the mission accomplished by now? We've already talked about the joints that are nearby. So this is the subtalar joint. We see that something's happening there already now with some arthritis. So the patient walked around for another year, and then came with pain in his subtalar joint as it was functionally overloaded. And we see that there is some beginning post-traumatic arthritis with the bony cysts in the area around the joint, and with some bony ingrowth on the edges of the joint. So at first we've performed the arthroscopically assisted removal of the arthritic changes, but it did not work. So we've performed the subtalar fusion in situ, because the hindfoot height was sufficient, and that's the way we do it primarily if we don't have any problem with the hindfoot height, not performing the distraction fusion, but a simple in situ fusion. These are the pictures that we became after the fusion surgery. What I wanted to show is that performing the fusion from the biomechanical point of view, we start with these screws that do perform the compression on the side. And as soon as we achieve the compression, then we opt for, I call it the so-called closing screw that holds the construct angularly stable. So this is some modification to the classical axial technique that we use. But still, in this patient, we did not achieve the fusion. You can see the CT scans some 7 months later, with a non-union there. Even though the cortices were removed, it came not to the fusion, and it comes again to loosening of the screws. So the question is now what to do. Which technique would you choose now for solving this problem in the subtalar joint?
This is a known problem. If the anchor is already fused and you have to do a subtalar fusion, even if it's in situ fusion, they tend to have more non-unions than primary isolated subtalar fusions. And so I would be generous from the beginning, because I had the same problem. Even if I do an in situ fusion, add some bone graft to it, some cancellous, some loose cancellous bone, squeeze it in, and then still do your compression, just the same technique as you did. One potential issue is also with the cannulated screws. What you see here, you buy the hole inside the screw for less distance between the threads and the core. So probably a solid screw sometimes has a greater jump in diameter between the core and the threads, and probably potentially has some more compression. So I would try another screw fusion, but with bone grafting and compression.
Yeah, and I currently add more often, after one compression screw partially threaded, I add a fully threaded screw to make sure that there's absolutely no more motion. I have the feeling that a fully threaded screw adds more stability than a cannulated screw.
Yeah, so in the first step, the compression, and then securing it with the fully threaded screw. Okay,
yes. We are now heading. You have a long way in the bone without threads for both screws. And
we're now heading towards the end of the session, so we must finish this case. Just in a short, we fused the subtalar joint with the hind foot fusion nail because I wanted to have some strong implant in the place, which did not lead to fully healing of the situation. As we see on the CTs 60 months after the initiation of this case, we see some ingrowth there in the dorsal part of the joint, but the patient was at that moment with a complex regional pain syndrome on chronic drug abuse, and was a bit socially dead because he lost his work and the family. So we've opted for perhaps a dramatic solution. We've performed a below-knee amputation using the Bruckner technique, which is more often used in Europe than in the rest of the world. But still, we had some issues with the stump necrosis, and we had to shorten up, re-amputate the patient. And now we see the situation 9 years after the initial trauma with the healed stump. He's fully mobile with prosthesis, and he had returned to work. Just to sum it up very briefly, the 5-screw fusion technique should not be used for cases with axial deformity or with large structural defects. On the other hand, the plate fusion can be used from the ventral or dorsal approach, has biomechanical superiority to the screw fusion, and can be used and should be used as a salvage or a technique for revisions. The amputations, I think of them always in patients which suffer from chronic regional pain syndrome, have a chronic drug abuse, and are somehow socially dead, so losing their social situation. So I'll now end up with the screen sharing.
Excellent. Great job, guys. Thank you so much. You guys already finished your first coffee. I'm in the middle of my first one. So.
Glenn told me he takes 2 coffees for the 24 hours. I can't believe that.
You're supernatural.
Yeah,
that's right. Excellent. Well, thank you so much, guys. We're going to end this session and start the next one in a minute.